At this point, we're going to transition to the panel session, and if people have a burning question to the mics, let us know. But otherwise, I think we have many. This is terrific. We have a lot of questions. We're going to start with Professor Tanek. Are the mics turned on here up front?
Yeah.
Great.
Okay. Yeah. I have one question here saying, is there any evidence of parental psychoeducation programs that improve compliance of medication treatment? And yes, there are. One of the studies that I referred to in the talk indicated that with increased understanding about ADHD, particularly its neurobiology, it made sense to why you might treat with medication. Intriguingly, in our work with teachers, as we also educate teachers about the neurobiology of ADHD, and as we educate children about what ADHD is, the children were finally understanding, and this is anecdotal, but were no longer spitting their pills out once they were given to parents. The other question I have is a fairly short one to answer. Is there any website for nursery school teachers for psychoeducation of hyperactive and impulsive kids? To my knowledge, there's not a specific website, but the website, the Canadian one, which we developed on Teach ADHD, addresses preschoolers, and the important thing for you and for the preschool teachers to understand is that the symptoms are present in preschool years. The executive, the cognitive deficits, and the ADHD symptoms manifest and persist. So many of the recommendations that are in the websites to deal with children for teachers are very appropriate for the preschool teachers. Okay. It's not.
Oh, is this Denise? Oh, I see. We passed the mic. We should get very close here. Or is this the only dead mic? Does yours work? All right. For pure ADHD, what is your treatment algorithm in your clinical practice? Like many people, first of all, non-comorbid ADHD, I assume that's what people are talking about. Clean, straightforward ADHD. If you have any of those cases, send them to Boston. I tend to get refractory train wrecks. They've had 12 trials and usually ended up in jail or something before I get the pleasure to clean them up in a week. But often people are starting with stimulants. A lot of people start with a stimulant first. That's your choice. Atomoxetine can be used first. I would use one of the approved products, either in the EU or the US, as a first-line agent. The comment here is, another question is atomoxetine for children with ADHD plus tics. I actually did a study with children with ADHD plus tics and found that the atomoxetine did not increase the rate of tics, and in fact there was a reduction in the tics. Now the study was called a non-inferiority study, so it was not powered to show that difference, but in fact if you looked at the data it had improvement in that group. I think part of that is through the anxiolytic property, and I think part of that is through its effects on tics. Tricyclic antidepressants like desipramine have been studied in children with ADHD and tics, and that also works for that group. For insomnia induced by stimulants, what is your suggestion? We use sleep hygiene discussions first to be sure the children get up at the same time, stay awake during the day, don't nap, don't drink caffeine, don't play video games late at night, etc. If that doesn't work, our first level is melatonin, which has now been demonstrated in randomized controlled trials to be effective in sleep disruption with ADHD. That's not effective. We use clonidine. If that's not effective, we use mirtazapine. I'm not sure that's available. Remeron is the brand name. If that's not effective, we use amitriptyline or imipramine. If that's not effective, we use a hammer. Now, I don't know what to do. If that doesn't work, usually by then it works. So, and then the last one is there any evidence base for recommending drug holidays for children on medications? It's a great question. There's something so satisfying about drug holiday, that words go together so well. I want to remind you, as Professor Tanek was commenting on, that attention is fundamental to life. You navigate through life because you have your attention and focus. Think of yourself if you've been on call the night before, if you're tired. And one of the impacts that has not only on your mood is your attention. And if you feel that way after being up all night, that's how somebody with ADHD is functioning day to day. They're at diminished capacity. In some cases, it's not a problem. It's reasonable for somebody, for example, who has weight issues on the medications. It's reasonable for somebody who has tics on the medication or is having difficulty tolerating it. Or it's reasonable for that small percentage of children who really only have functional deficits in regards to academics related to school. Other than that, we're recommending continuing the medication. One of the tricks you have, however, that seems to be helpful is it's not at all clear that the dose response of medicine is the same in academic undertakings as it is for general activities. So one of the things you can think about doing is reducing the dose by 1/3 to a half to see if the child is still functioning well in all the domains and can tolerate having the reduced dose of the medication. That's just one of the tricks over the summer. But just to give you a sense, U.S. pediatricians actually reduce the amount of prescribing for stimulants by 1/3. They literally are taking 1/3 of their children off the medication, or half of the children off medication during that period, and that's probably excessive. Don't leave it up to the parents to make that decision. There's too much guilt in that decision. It really needs to come from you, the practitioner, if it seems reasonable or not.
Okay, I was asked, why is psychological treatment in adults more important than in children? Children will, in the end, become an adult. And yes, I agree. I think in childhood there's a lot of support for children in terms of the school, the educational structures. There's a lot of support around children, and there's less in adults. But that doesn't mean to say that, of course, children don't need psychological treatment. I mean, the MTA study, as I said, with the Rolls-Royce of behavioural programs that I think couldn't be replicated anywhere, suggested that it didn't add much over and above. But certainly in the United Kingdom, children will often be started on psychological treatment first, and to see how things go, some children, that will happen. I was asked whether we can extrapolate a study done in one country, for example in Scotland, to two others, like in England and Wales, because they have different legal systems and what have you. Well, first of all, the legal system in England and Wales is the same. It's considered together. And what I did is I gave this as a guide. I'm not formally extrapolating and saying this is what the case in Scotland, so this is what it would be definitely in the UK. However, I would say that I can't see how the different legal systems will impact hugely on the characteristics of the offenders or their motivations for offending. And it's about thinking about who the offenders are and what's led them to be offenders, and the role that ADHD might have played in that. How many people with ADHD have personality disorder? Well, we really need epidemiological studies, longitudinal studies, to answer that question, and to my knowledge there haven't been any. Clinical rates, I know in our clinic at the Maudsley we found, I think, I'm taking a figure from my memory, but I think it was 23%, and this was reported in Youngtoon and Tyson in 2003 in personality and individual differences. Most of them, the personality disorders, are kind of cluster B, disorganised type disorders, antisocial behaviour, borderline. And of interest, though, I've often had many kind of discussions with some of my colleagues at the Maudsley, where we wonder whether people with ADHD and who have an outcome of personality disorder, whether this really is personality disorder or whether this is their symptoms. Some people view this, they disagree that it's personality disorder and say, well, this is really a manifestation of their symptoms in adulthood, the disorganisation, for example. Last question was, can we apply the unboundment programme to teenagers? And the answer is yes.
I have a really intriguing question here. Is there any distinction between the effect of psychoeducation from the effects of medication? And there are a couple of ways I want to approach this. There is no simple answer. I think what it's addressing is two things. One is what I call the timing of intervention. All the studies that I reported were not psychoeducation issued in the office immediately following diagnosis. So therefore, I think the evidence will suggest that we need to take into account two things. One is what I call the readiness for treatment. Prochanska has outlined different stages. And I think what we find is that the programs that were reporting effective outcomes from psychoeducation, the patients and their families had had time to kind of sit a little bit and think. The second way I can address this question is that if I look at psychoeducation with or without the particular family receiving medication or the patient receiving medication, to me, again, in the studies, that many of the youngsters in those studies I reported were actually being treated with medication. And thus it suggests that there might be a window of opportunity. The kind of crisis has calmed a little bit. But also it means that the individuals and the family might be more able to take the information in. Has there been another one is, has there been a direct head-to-head comparison of psychoeducation versus medication? And to my knowledge, no, there hasn't. I was not present. I think there was a presentation yesterday that referred to psychoeducation in the presence of a pharmacological treatment, but I don't know the outcome of that. And another question is, what do we know about the effectiveness of children's books about ADHD as tools of psychoeducation? And again, I think this is a wonderful opportunity for a study, for investigation. We often use the books about ADHD. Many of my graduate students have done various projects on this, and if you do a task or an item analysis, the books are great for parents because the language is direct and simple enough that the parent can understand. However, the language is often not necessarily optimum for children. So sometimes the children don't get as much out of the books as the parents do. In other words, that I think many of these children's books for ADHD need a parent or a clinician as a mediator to try and point things out because they're so crowded with pictures and words. Remember that the children with ADHD have great difficulty in knowing what is the salient information to identify. So sometimes I think these books definitely need a mediator. You can't just hand it to a child and think they'll understand. But we don't have good research on that.
I have a number of rapid-fire question answers here. Questions. I'm not sure I have answers. But first is, does clonidine alter REM sleep, used for sleep, when used for sleep? The answer is it does. That's the bad news. The good news is, according to Tom Roth, who's one of the world's experts on that specific interaction, it's clinically insignificant. What about modafinil? Modafinil is also a trade name Provigil. It's a narcoleptic agent. It works through histamine, probably also through dopamine, by the way, at the doses you're giving. 5 controlled trials in pediatrics, 5 positive studies. Almost was FDA approved, but was associated with a very severe skin rash in a few of the individuals in the trial. One who had what's called erythema multiforme major, Stevens-Johnson, so subsequently received what's called unapprovable, which means it's not going to be approved for use as a marketed product in the United States. 2 trials, interestingly enough, in adults. This is one of the few times there's been a separation in pharmacologic response in adults versus children. The 2 large multi-site studies that have been done in adults, both negative. Positive kids, negative in adults. So 7 controlled trials in general. What about the use of atomoxetine in preschool children? The best person to refer to that is Chris Cradiville, who's done secondary analysis of existing data sets in younger children, 6 to 8-year-olds on the medication. In general, it works. But the data would also indicate you have to watch weight, the same way you do with stimulants, particularly in that age group. There was a weight effect in the younger age group. We published this together, and we were struck by that. I'm assured in the follow-up that seems to be a wash, that they grow out of the weight effect and that there's been no long-term effects by it, but there appears to be that effect. In children younger than the age of 6, there are studies underway, and I'm not sure of any existing data that's been presented or published yet. What about the effects of treating current active substance users with stimulants and or atomoxetine? The data would show, and there have been 4 controlled trials that have done that treating through active substance abuse, either cocaine or alcohol, just treating current active substance abuse with medicines does nothing for the ADD, does nothing for the substance use. So you have to get a toehold in on the addiction and then treat. And that's what we did with the atomoxetine study and found a significant effect. If people were clean from their alcohol from between 4 to 30 days, so they're at very high risk to relapse, but they were clean at the time we started the atomoxetine. So the next generation studies need to be in that route. There is a large multi-site study using extended-release methylphenidate in adolescents who are substance abusers. This is a NIDA-funded from our government-funded multi-site study. Results are pending. There's also a large study in current cigarette smokers, adults who are cigarette smokers, given active extended-release methylphenidate or placebo and followed for 12 weeks. Results are pending right now. I can tell you that the midpoint analysis did not show a worsening in the cigarette smoking, only because of the review. That's all you know about. But there was nothing else at this point. Stay tuned. Probably at next year's meetings we'll have the results of these large multi-site studies that are almost equivalent in size to the MTA in terms of how large they are and how important they're going to be in the substance abuse. Can we turn on the microphone in the back there? I'm not sure. Is it a good question? Is it worth turning on the mic? No, it's whatever. Please, go ahead.
We have a number of young people who are with ADHD who are medication, who are taking substances such as cannabis at weekends and things like that. And I just wonder what realistic advice we should be giving them in terms of how we.
This will be the last question because of our time here. I think. What's that? Do we have? Probably. The question is. In the UK, and this is, I have to tell you, this only happens in the UK. We've never had this problem in the US, and that is that we have some of our sweethearts who are being treated for their ADHD or smoking marijuana or drinking on the weekends or smoking cigarettes, etc. And what practical advice do we give? And that may vary by the panelists. Working in that area, I have a very succinct conversation with the parents and the children. And I start this, by the way, in 5th grade, but for these kids, I really sit them down. I talk to them about the risk that ADHD begets on substance use disorders, twice the risk of an addiction. I no longer use these little easy terms around them. I use, you have a much higher chance of being an addict, being an alcoholic. You have to be very, very careful about any substance you use. So that kind of a psychoeducation, aggressive psychoeducation, right up front with them is important. Number 2, if they're using intermittently, I continue treatment. If they start using more than intermittently, which it's before school, at night, during school nights, or they're heavy drinking, getting into risk situations, those situations, I'll pull the medication away to give a very solid signal to them, have a family meeting, a very brief family meeting, during my 15 minutes. You can try to do family therapy in 15 minutes. But to really talk to them about this issue, and if they continue doing it, then we usually get them a counselor. For intermittent rare use, I continue treating through it with discussion, keep the alliance going. But much more than that, you have to do something. I think at this point, for time considerations, I want to be sure that everybody turns in their handsets. These aren't cell phones, or they don't work when you leave the room. So if you could please turn those back, that would be very good. Evaluation forms, there's a series of evaluations here. If you could please fill these out. This is very important for feedback. If you could hand them out to the stewards at the exit, I'd appreciate it. I want to thank Lily for sponsoring this. I want to thank all of you for coming and staying all afternoon, and I want to thank my panelists for coming in to give these wonderful talks. Thank you.